At the outset, let me express my sincere thanks and obeisance to my teachers, Dr. M.K. Mani, my guru, Dr. K.S. Ramalingam, my mentor, Dr. Rajan Ravichandran, my friend, colleague, for shaping me into a nephrologist. I have been into nephrology for the last 40 years. In the first 2 decades, when I went actually for taking rounds in the dialysis units, I was negatively affected by few factors, namely, many patients actually with no urine or less urine come with fluid overload, pulmonary edema, breathing difficulty, on the way dying, and then soon after actually coming to the hospital, actually dying. They used to be on 4 or 5 antihypertensive medications and other drugs with an enormous pill burden. Every alternate day, they have to come to the hospital, spend 4 to 6 hours for dialysis, losing their precious productive life. And over the years, actually losing the attention of the family members and then the cost constraint. And most importantly, not allowed to eat what they want to eat actually. All these things actually were in my mind, and then it was a big problem in my mind actually running actually for years. And 2008, it became very strong. Then it was actually in the back of my mind actually I was trying to how to help the patients and how to prevent this disease at all. That means actually preventing this disease, that means I have to prevent the non-communicable diseases such as hypertension, diabetes, atherosclerosis, etc. And then if I'm going to prevent the NCDs, then I have to look at the root causes of the CKD. In case once I'm going to prevent all these things, I'm going to prevent the cerebrovascular diseases and then ischemic heart disease and so on and so forth. So I started working on this, how to go about from 2008 onwards. Thanks to Dr. Ravichandran and his team for having given me an opportunity to talk on the salt substitutes and my experience. There are 4 important actually causes, actually for the root causes of NCDs responsible for CKD, namely salt toxicity. Then we have the intracellular potassium deficiency, and then subclinical chronic acidosis, and then the biggest, the insulin toxicity. Salt toxicity comes in actually when there is high salt intake, and in addition, there is a salt retention, as actually Dr. Sambat Kumar was telling. These are the unrecognized entities wherein actually the salt is retained. That is actually intracellular potassium deficiency, subclinical chronic acidosis, or insulin toxicity. About that, I will talk to you in a little while. Salt addiction is universal. Once actually a person is actually has enjoyed the taste of salt, he gets addicted. It has become universal. With about 20 million tons of consumption of salt across the world, we keep losing actually 10.1 million deaths per year. A huge number. 20 million tons consumed every year. What makes the salt? I'm not going to the details of what makes the salt into toxin. And most importantly, this is actually, I will tell you actually, I think Dr. Sambat Kumar was talking about the salt intake actually by the Yanomamo Indians in Amazon forest actually. You can see that actually our average salt intake is actually, global average is 10.6 grams, and what we require is actually only 500 milligram of sodium either or 1.25 grams of salt. That's good enough. And that can be met easily with actually the foods we normally take without added salt. Anything above that, we are going to develop actually salt toxicity. And when it exceeds actually more than 1.25 gram to 3.75 grams, and we are going to develop actually non-blood pressure related toxicity. When it exceeds more than 3.75 grams, then we are going to develop actually high blood pressure itself. These are the combined pressure, non-pressure related vascular disease related toxicity, which I am not going to elaborate on that. Already talked by several speakers. And these are the other than non-pressure related disorders, including cancers. But I think Dr. Shaw was talking about cancer, stomach, all those things. Coming to potassium, Sampath Kumar was talking about the potassium distal convoluted tubule actually. Our potassium intake has enormously come down. If you look at the over a period of 7 million years, actually starting from, If you look at the retrojected diet actually studied during the Paleolithic actually time, the potassium intake used to be up to 800 milliequivalents per day. Our global average has come down to less than 40 milliequivalents in the modern diet. That means actually what happened is actually the intracellular potassium, which used to be around 160 milliequivalents per liter, has come down to 110 to 115 milliliters per liter, milliequivalents per liter. That means there is an enormous reduction in the intracellular potassium. So with that, actually what happens is actually the sodium excretion by the distal convoluted tubule actually gets reduced, resulting in salt retention. So what are the problems associated with the low intracellular potassium? These are the actually hypertension primary, and then we have a number of diseases actually. And the list is really very, very long. These are the benefits of optimal dietary potassium. What is optimal dietary potassium? It has to be at least actually about 90 milliequivalents per day. That means actually not less than, somebody was telling about the WHO recommendation of 3,510 milligrams in a day. Minimum it has to be. That is equivalent to 90 milliequivalents of potassium per day. When that is not the optimal, that is actually at least the minimum. The optimal would be somewhere around actually 400 plus or minus 25 milliequivalents actually per day. That is the optimal. And then there is no need to worry about the dietary potassium intake. Nobody has developed in my study hyperkalemia, and there is no restriction required actually, especially in the general population. There is no need to worry about dietary potassium at all, because there is no upper limit for that actually. Again, the long list of potassium benefits, especially in the presence of alkaline pH. Then some more. Again, these are the benefits of potassium. I am not going to talk about all these things in detail. Then we come to actually subclinical chronic acidosis, the forgotten clinical entity. Let us see what happens actually. This is the pre-agricultural ura. Actually, if you look at the net endogenous acid production, it is actually minus 77.7. That means actually phenomenally alkaline, the Paleolithic diet. Now, you look at that actually now, what is the current intake actually plus 72.8 milliequivalents per day. What happens is that actually with the subclinical low-grade chronic acidosis which prevails across the world, what happens is actually there is a reabsorption of sodium from the proximal tubule, and then actually that results in salt and water retention, paving the way for salt toxicity. If you are interested actually into maintaining the optimal pH actually, one can do either the plasma pH, make sure that it is above 7.41 to 7.425, or you can do the spot urine for citrate, which has to be not less than 320 milligrams per liter, or if you are going through 24 hours excretion of citrate, it has to be anything more than 640 milligrams. And these are the problems associated with the subclinical chronic acidosis. Then you can see that hypertension is there actually. Then we have the insulin toxicity, under-recognized, under-studied, under-acknowledged problem. But what is the number that I probably will come to know in a little while. The root cause for all the non-communicable diseases, whether it is atherosclerosis, whether it is hypertension, whether it is obesity, whether it is cancer, it is only insulin toxicity. 75% of the total death because of the non-communicable diseases are attributable to insulin toxicity. How does it produce actually salt and water retention? Our daily requirement of actually insulin is 30 units a day. And if you do the 24 hours urine excretion for insulin, it will be normally actually 0.014. If somebody actually is having actually 0.1 unit of actually insulin excreted in 24 hours, that patient has got actually insulin resistance. Either he can do the insulin level postprandial or fasting, or actually according to what I have been doing, I just tell you. And this is the normal levels and the random level of insulin. I have done actually over the years about 7,705 insulin tests actually. And then if you look at this actually, it's absolutely normal sugars. Fasting is 79 and then post-glucose is actually 81. If you look at the post-glucose actually, insulin level 336. That means absolutely euglycemic, very badly hyperinsulinic. What is the percentage of people? I'll let you know. This is the pattern. Actually, you can divide the population into insulin resistant and insulin sensitive. And this is the study. Actually, this is the study based on actually the Robert Kraft. So he studied actually, started his work in 1970 and then up to 2017, he studied actually 16,304 patients actually. He did for all the patients actually 7 samples, which I modified into what is called actually modified Kraft model. You can see that normal insulin with normal blood sugar, that is actually around 15%. That means only 15% of the people are having normal insulin level. Low insulin with high blood sugar, that is the type 1 pediatric diabetes, actually only just 2 crore of people, less than actually 0.3%. High insulin with high blood sugar, you can see 42 crore actually, that is the frank type 2 diabetes, and high insulin with the pre-diabetes actually again 66 crore. And look at this, alarming actually, high insulin with normal sugar, 500 crore, 5 billion people. That means actually they enjoy normal sugar and then absolutely on the higher side the insulin. So totally, you have about 608 crore of people actually having high level of insulin. How does this contribute actually to salt and water retention? The insulin, when it is on the higher side, it acts through the entire length of the nephron and facilitates vivid reabsorption of sodium, resulting in sodium and water retention. That would mean this many number of patients actually they have the potential to retain salt and water. These are the diseases, actually non-communicable diseases attributable to actually the biggest killer. And then actually hypertension is not an exception. Now actually with the aim to prevent, with the aim to control and then retard the progression and reverse the disease and possibly to eliminate what to be done. That too, if it is possible, actually by simple measures like diet, salt substitutes, and other supplements, it is nothing like that. So I designed myself a diet called actually Dr. N.M.'s IRS diet. IRS stands for Insulin Resistance Syndrome Diet, which would mean actually 60% of the calorie would come from the healthy fats, 25% of the calorie would come from complex carbohydrate. Please remember, it's a complex carbohydrate, and then 15% of them would come from the protein. Then, of course, the salt substitutes. Broadly, I can say that actually, as Dr. Edin was telling, actually, it's a potassium-based and then non-potassium-based. There is potassium-based low sodium or no sodium salt substitute, no potassium or no sodium salt substitutes, and supplements. These are the supplements, again, my own product actually. I keep remembering my boss actually, so Dr. M.K. Mani, so I put this name as MKM capsule, which is nothing but magnesium and kalium actually containing a product actually. Then this is the frank KBC, potassium bicarbonate, and we have the other one, the FAIR, Fighters Against Insulin Resistance. In our unit, actually, we don't use insulin at all, either, or the insulin augmenters like glibenclamide. We stopped using it for the last 7-8 years because I recognize insulin as the most important toxin in the world and taking actually 75% of all the deaths. The advantage is actually nobody develops actually hypoglycemia, number one. Number two, the treatment becomes easier, and then totally avoiding insulin toxicity. So I have been working on this salt substitutes from right from 2008, and I have been actually, I would have tried more than 1,000 formulations actually to bring it to taste. Just not one actually. I think he was enumerating, Dr. Fernando was enumerating a number of actually these taste enhancers, but I failed several times actually until 2017. Then I could actually achieve the palatable salt. These are the number of patients actually all put together, 10,321. The community salt, which is 50% less sodium, 4,831. Community salt premium, 70% less sodium. And then O salt actually, that is totally free from sodium. This I designed it actually for the entire community around the world. This one I have designed it actually for the resistant, refractory, or malignant or accelerated hypertension. And this one actually for all the idiomatous disorders except renal failure, such as, cardiac failure, liver cell failure, nephrotic syndrome, all those things actually. 100% actually sodium free. And then the renal failure salt, which is no sodium, no potassium. So we have about 1,250 patients on actually renal failure salt also. I have a patient of 336 on dialysis. All of them are on this RF salt, and the remaining are actually the waiting for dialysis, actually pre-dialysis patients. This is the breakup actually over the years. This many number, and 10,321. A little more detail about the community salt actually, which I have designed just for not Pondicherrians or the Tamil Nadu or India, for across the world actually, because it is designed as per the WHO standard. WHO recommends actually a reduction of salt actually by 5 grams, which I have done it in this. And then you can look at the other parameters. I have made actually potassium actually 1,755, exactly half of the minimum recommendation. That is 3,510 milligrams of potassium daily. In that, half of that I have included in this. And then about 25% of actually daily requirement of calcium, and about actually, 50% of calcium, and then 25% of magnesium. I made the salt also alkaline. Normal salt is actually 7. This is actually 7.6. And then it will be, that is because actually, because of that actually you will get actually 60 milliequivalents actually equivalent to bicarbonate. Otherwise actually if you are taking actually soda bicarbonate half a gram, that is which will provide actually 6 milliequivalents of bicarbonate, so much of bicarbonate you will be getting it. It is alkaline. And then I think Dr. Fernando was talking about the sodium-potassium ratio. The sodium-potassium ratio recommended by the WHO, the European Union, and the American Heart Association is actually 1.8, and I have kept it actually even far below that, actually 1.1. And this is palatable salt, and I don't think actually we'll be able to differentiate. There's no problem with the salt at all. I have kept actually the few samples of Muruk in the registration counter made out of actually 50 for the community salt. The interested audience can actually taste it. RF salt, actually this is for the nephrologist actually. You can see that actually apart from sodium, we are going to come down on antihypertensives and then potassium, and then we will be providing elemental calcium 861 milligrams, and then 30 milliequivalents of actually bicarbonate precursor. That means actually very easy to handle the chronic renal failure patients. And what is the conclusion? The Dr. N.M.'s community salt and community salt premium are as tasty as common salt. NM's O salt and RF salt are not the exceptions. No metallic, no bitter or any other unpleasant aftertaste, no side effect including nausea, therefore easy and ready acceptability leading to better comfort level and nutrition. A remarkable reduction in the antihypertensive medication, diuretics and other drugs resulting in reduced pill burden and cost constraint. Potassium-based Dr. NM's salt alternatives not only serve as the salt substitutes but also as carriers of essential nutrients including potassium, magnesium, calcium and waste precursor. RF salt is unique without sodium and potassium but substantially supplementing calcium and waste precursor, both most required by the kidney failure patients. Shelf life is excellent and would become cost effective in the near future. All the Dr. NM's salt substitutes along with the Dr. NM's RS diet and other supplements including capsules of FAR, KBC and MKM are intended for preventing, controlling, retarding, reversing and possibly eliminating all the NCDs from this planet. Thank you very much.